Hey everybody, it's Robert Libby, registered massage therapist and instructor of ligamentous articular strain technique, coming to you from the all-inclusive tropical resort of Prince George, British Columbia. No, I'm not coming to you from an all-inclusive tropical resort. I am coming to you from Prince George, but I'm just having a little bit of fun with the effects that you can have with your camera with your MacBook. So I figured, what the hell? It's a tropical destination. We'd all love to be on vacation right now. And I thought that I would bring you just a quick little video about some hints that we discussed in this previous weekend's and last weekend, this previous weekend's course in Prince George, and the last weekend's course in Red Deer, Alberta. So both weekends we dealt with dysfunctions of the shoulder complex and dysfunctions of the hip and pelvis. And a couple of the hints that I want you guys to sort of think about is that when you're looking for dysfunctions of the glenohumeral joint, when some patient comes into you and they are coming to you complaining of dysfunction or pain or tension from either a mechanism of injury or just an insidious onset to the glenohumeral side of the shoulder, I'd like you guys to start looking at some of the dysfunctions for the sternoclavicular joint. So I have sternoclavicular joint right here, and we know that the force coupling mechanism for the clavicle is that when you take a deep breath in, it should rotate posterior superior. When you take a deep breath out, it should roll anterior and inferior. And if you've got some dysfunction that's happening at the lateral aspect of the glenohumeral joint, I want you to look for the dysfunction at the sternoclavicular joint, the proximal end of the sternoclavicular joint, because I guarantee you that a lot of people don't go here. It's kind of like, I sort of make it the joke that in the movie Kindergarten Cop, Arnold Schwarzenegger says, you know, who's your daddy and what does he do? When most of my patients, when they come into the office, I say, what practitioner have you been to see, and what story have they told you about what's happening at the glenohumeral joint or the femoral acetabular joint or anything that they come in with? Because I like to see what everybody else has done. What is the route? What's the path? What's the investigation process that everybody else has gone on, so that I don't have to go there? They've already been through there. The person has seen everybody. They've done everything through that area. And typically I tend to find that a lot of people haven't gone here. They haven't gone to look for the dysfunction of the sternoclavicular joint capsule and the ligamentous tissues. So my suggestion is to start here first. Now, in starting here, I would also love for you guys to actually assess and treat the first rib and the costoclavicular ligament that sits right underneath the clavicle. If there is a dysfunction at the first rib, or the first rib is either sitting inferiorly or if it's sitting superiorly, this clavicle is going to sort of be influenced in kind with that. So we work with, my suggestion for you is to work with the first rib anteriorly first, then reassess the dysfunction at the clavicle. Now, the next thing I want you to do is I want you to look at functional patterns for the glenohumeral joint capsule and what is the stretch tolerance for the long head biceps. Now, there's a lot of research showing the attachment points for long head biceps into the glenoid fossa and being influenced by the superior glenohumeral ligamentous tissue. And there's a lot of pain and discomfort and dysfunction that can happen in through here, protective mechanisms that can be in through here. And if you've got a clavicle that is sitting in sort of a posterior superior position and you want to take it into an anterior inferior position, taking the glenohumeral capsule and increasing that stretch tolerance for the long head biceps is really going to have an amazing result influencing this clavicle in the direction that we want it to go in. So before you treat the dysfunctions at the sternoclavicular joint, look at first rib, costoclavicular ligament, look at stretch tolerance for long head biceps, make a change, make an influence to both of those, then reassess the clavicle, see what's left over, and then you can go to work and you can clean that up. If you'd like more information on how to do that, I've got my online course for the shoulder that you can enroll in, you can register in, and I cover all of that in that course. Absolutely fantastic course. So I would encourage you guys to utilize that in your practice with your patients on a daily basis. Now, the other thing that I want to address is we also talked about treatment techniques for the iliofemoral, the pubofemoral, the iliofemoral, and the ischiofemoral on the posterior aspect of the head of the femur. Now, there's a lot of myth and trend into how to effectively treat the joint capsule of the femur, and I think what people need to recognize is that the research shows that you need to get this head of the femur into specific ranges in order to have the best influence with each of the individual tissues that you're trying to have influence or access on. So for example, with the iliofemoral ligamentous tissue, you need to have their leg, your patient's leg, into 20 degrees of extension before you can effectively influence that structure. If you're looking at the pubofemoral ligamentous tissue, you actually have to take that tissue into about 50 degrees of abduction before, again, you can have influence on that. And with the ischiofemoral in the back, you've got to take the head of the femur, you've got to internally rotate it 40 degrees in order to effectively treat that tissue. Now, if along the way, when you are trying to get those the head of the femur into those specific ranges, and you get protective mechanisms, you get guarding through the hamstrings, through the quadriceps, through the adductors, through the glutes, through the low back, you need to go and you need to treat that effectively first, and then come back and take the head of the femur into these positions in order to access those structures. With some of the stuff that I've seen live in person, when I've had students show me examples of how they think they've been affecting either the head of the humerus or the head of the femur, I see a lot of movement of skin or movement of muscle tissue, but the bone is staying stationary. You're not moving the bone. If you're not moving the bone and the joint, you're not having influence with the joint capsule and the ligamentous tissue. We need to continue to incorporate research into our practice in order to better treat our patients and to more effectively treat our patients, and to really challenge some of the techniques that we've been taught throughout time, and really sort of ask ourselves, are we being as effective as we can with those tools and those techniques? We need to remember that there's the skin fascia frictionless interface system, which basically says that you need to be at 90 degrees in order to effectively have contact with the joint in order to influence the joint, or you need to lever it in order to have influence on those tissues. So if I have my skin and I'm moving my skin right now, I'm not having an influence with the muscle tissue directly underneath it. If I take the muscle tissue and I move my muscle tissue on my forearm, well, the skin is moving, the muscle's moving, but the joint is not moving. Now I can hold my muscle tissue, I can move my joint, and there is no effect on the muscle tissue whatsoever. So you really do need to remember that there's a skin fascia frictionless interface system. If you want to have access to the soft tissue, then there are techniques for that. If you want to have access directly with the joint capsule, with the ligamentous tissue, with the articular structures, then there are techniques for that also, but they're not the same technique. So I cover all of that in my soon-to-be-released online course for the hip and pelvis. We cover all that stuff. I show you the specific angles and degrees in order to get the most access with those joint tissues. So I really hope that you guys sort of incorporate research into your practice. There's a ton of amazing comments and discussions that are happening through social media right now. A lot of people are linking research papers. What I tend to find is that there's sort of a polarization that sort of occurs, and you really can't be polarized. You can't really be polarized one way or the other. It's always this way, it's always that way. You have to aim for the fence. You have to aim for the fence. You have to take the research from both sides. You have to read it, and you have to incorporate it into your practice and really see, where does it fit in? How can I incorporate this into my practice? What am I comfortable with? And really challenge yourself to think a little bit differently. Incorporate the research, read the research. If it challenges some of the myth and trends that you're believing in, you're biased towards, then great. Open up your mind, think a little bit differently, And if it's a new perspective and you can incorporate that into your practice to improve the quality of life of your patients, well then that's all that we're here to do. That's absolutely fantastic. So I hope you enjoyed those sort of 5 little hints about working with the clavicle, work with the first rib, the costo-clavicular ligamentous tissue, increase the stretch tolerance for the long head biceps, the anterior glenohumeral joint capsule. Remember those degrees that you have to get the head of the femur into in order to effectively treat the ligamentous tissue of the joint capsule, the articular tissues of the femoral acetabular joint capsule, and keep on reading the research, keep on integrating it into your practice. Look at all of the discussions that are happening on social media, and just sort of try and improve your practice, challenge your beliefs, challenge your biases, and always be trying to improve the quality of service that you provide to your patient and ensuring as much patient safety as you can. So that's it for me from the tropical resort of Prince George, British Columbia. I hope you guys enjoyed the video. If you like the video, share it on your site, and hit me up, send me an email, let me know what you think, and I'll talk to you guys later. Bye guys.